Plot twist nobody puts in the pamphlet. The pill your cardiologist handed you for your blood pressure, the antibiotic your dermatologist prescribed for your acne, the acid reflux medication sitting in your bathroom cabinet right now, any one of those could, theoretically, be quietly assembling a full-blown autoimmune disease inside you. Not because anything's contaminated. Not because of some shady manufacturing scandal. Just because that's a known, documented, decades-old side effect of a surprisingly long list of everyday medications. It's called drug-induced lupus, and today we are building the entire wanted poster, every drug on it, every symptom to watch for, and exactly what happens once you catch the culprit red-handed. Before we get into the lineup, I want to set expectations correctly, because this topic has a tendency to spiral into unnecessary panic if it's handled carelessly, and that's genuinely the opposite of what I'm going for here. This isn't a video about medications secretly being dangerous. Every drug we are about to talk about is a legitimate, effective, frequently life-saving treatment for a real medical condition. What we are talking about is a specific, well-documented, generally reversible side effect that shows up in a minority of long-term users. Worth knowing about, absolutely, but not a reason to eye your medicine cabinet like it's plotting against you. Let's start with the confusing part, because I don't want you doom-scrolling your medicine cabinet without context first. Lupus, broadly, is your immune system deciding your own body is the enemy and launching a slow-motion assault on it. Joints, skin, blood cells, sometimes organs, all fair game. Most of the time, lupus shows up for reasons nobody fully understands. Genetics loading the gun, environment maybe pulling the trigger. But drug-induced lupus is different. Drug-induced lupus has a named suspect. A specific medication walks in, spends months or sometimes years quietly rearranging your immune system's priorities, and then, surprise, you're suddenly dealing with joint pain, fatigue, and a rash that has absolutely nothing to do with the reason you started taking that medication in the first place. Here's the mechanism in plain terms, because I think understanding the how makes the whole rest of this video click into place. Some medications, once metabolized in your body, get chemically transformed in a way that makes your immune system's surveillance systems mistake ordinary cellular components, specifically proteins called histons, which your DNA wraps around like thread around a spool, for foreign invaders. Your immune system starts manufacturing antibodies against your own histons, essentially flagging a completely normal, essential part of your own cells as suspicious. That misdirected antibody production is what actually drives the joint pain, the fatigue, and the rash. It's not the drug directly attacking your joints. It's the drug accidentally reprogramming your immune system's target list. If your brain just went, wait, I need to know which drugs, type which ones in the comments, because that's exactly where we're headed right now. Category 1, and honestly the most notorious one in this entire lineup, heart and blood pressure medications. Leading the pack is hydralazine, a blood pressure medication that's basically the original suspect in this whole mystery. It's one of the first drugs every medical student learns can trigger this. In fact, hydralazine-induced lupus was first documented all the way back in 1953, which makes this quite literally one of the oldest, most thoroughly studied drug side effect stories in modern medicine. Decades of case reports, decades of research, and the pattern has held up remarkably consistently the entire time. And the numbers here aren't small. Long-term hydralazine use carries roughly a 5 to 10% risk of triggering drug-induced lupus. That's not a rare fluke. That's a genuinely meaningful slice of long-term users, meaning if you lined up 20 people who'd been on this medication for years, statistically, 1 or 2 of them could be dealing with this. Interestingly, research has found that genetics play a real role in who ends up in that unlucky percentage. Certain genetic markers related to how your body metabolizes the drug and certain immune system genetic variants appear to meaningfully raise or lower an individual's personal risk, which is part of why some long-term hydralazine patients never develop a hint of this while others do. Right behind it is procainamide, used for heart rhythm problems, and its number is even more dramatic. Up to roughly 20% of patients on long-term procainamide develop drug-induced lupus. 1 in 5. That's not a warning label footnote, that's practically a coin flip with extra steps. If you're on procainamide long-term, this genuinely isn't a maybe, theoretically, in rare cases side effect. It's common enough that most cardiologists prescribing it long-term are already watching for it as a matter of routine practice. Rounding out this category is quinidine, another heart rhythm medication with the same troublemaking reputation. Interestingly, quinidine and procainamide don't just share a symptom profile, they also tend to produce a specific additional antibody category called antiphospholipid antibodies, which in some cases have been associated with an increased clotting risk on top of the classic lupus-like symptoms. That's a detail worth your doctor knowing about, specifically if you're on either of these medications long-term, since it adds one more thing worth monitoring for beyond the standard joint pain and fatigue picture. Category 2, the neurological and psychiatric lineup. A handful of seizure medications belong on this list. Carbamazepine, phenytoin, and ethosuximide all carry documented links to drug-induced lupus. And sitting right alongside them is chlorpromazine, an older antipsychotic medication that, decades ago, helped researchers first understand this whole phenomenon in the first place. This category is a good moment to pause and appreciate just how strange this entire condition is, medically speaking. You've got a seizure medication and an antipsychotic, two drug classes that work through completely different mechanisms, targeting completely different systems in the body, somehow converging on the exact same downstream immune misfire as a heart rhythm medication and a blood pressure pill. That's part of what makes drug-induced lupus such an enduring area of medical curiosity. It's not one specific chemical structure causing this. It's a shared downstream immune consequence that a surprisingly diverse cast of unrelated medications can all independently trigger, almost like several completely different keys somehow fitting the exact same lock. If you just recognized a medication a family member takes daily on this list, type "noticed" in the comments. This isn't about panic, it's about knowing what to watch for, which is the entire point of this video. Category 3, and this one genuinely surprises people, everyday antibiotics. Isoniazid, used to treat tuberculosis, is a classic on this list. But the one I want you to actually remember is minocycline, an extremely common antibiotic, frequently prescribed for acne, that clinicians see triggering this condition regularly enough that it's practically become its own specialty topic in dermatology and rheumatology circles. Think about who's actually taking minocycline long-term for a second, because it makes this particular entry hit differently than the others. This isn't typically a medication prescribed to someone in their 60s managing a chronic heart condition. This is frequently a teenager or a young adult, prescribed months or sometimes years of continuous antibiotic use for persistent acne, a demographic that, statistically, is about as far as you can get from anyone's mental image of at risk for an autoimmune disease. That mismatch is exactly why minocycline-induced lupus catches so many patients and even some doctors off guard. Nobody's watching for autoimmune symptoms in a healthy 22-year-old on long-term acne medication, which means the joint pain, fatigue, or unusual rash that shows up can get chalked up to almost anything else first: stress, overwork, a random virus, before anyone circles back to the acne prescription sitting quietly in the bathroom cabinet. Here's a genuinely fascinating wrinkle: minocycline-induced lupus doesn't always play by the classic rules. Unlike hydralazine or procainamide cases, minocycline-triggered lupus is often negative on the antibody test doctors usually rely on for this diagnosis, and instead shows up positive on a completely different antibody marker in the vast majority of cases. Same disease, different fingerprint, which makes it one of the trickier versions to actually pin down. On top of that, minocycline-induced lupus has been documented producing some genuinely unusual additional features beyond the standard picture, including Raynaud's-like circulation symptoms in the fingers, distinctive skin lesions, and in some cases, liver-related abnormalities, which means a doctor unfamiliar with minocycline's specific reputation might not immediately connect all of these dots back to a single underlying cause. Category 4, the rheumatology medications, which is almost poetic when you think about it. Drugs literally prescribed to calm an overactive immune system, occasionally causing a completely different overactive immune system problem instead. The TNF-alpha inhibitors, infliximab, etanercept, and adalimumab, the biologic heavy hitters used for rheumatoid arthritis, psoriatic arthritis, and a long list of other inflammatory conditions, carry a documented, if uncommon, risk of triggering drug-induced lupus. Let's actually unpack the irony here for a second, because it's genuinely one of the more mind-bending details in this whole video. TNF-alpha is a signaling molecule your immune system uses to coordinate inflammation. These biologic medications work by blocking that specific signal, which is exactly why they're so effective for conditions driven by excess inflammation. But immune systems are staggeringly complex, interconnected networks, not simple on-off switches, and turning down one specific inflammatory pathway can, in a small subset of patients, cause other parts of the immune system to compensate in unexpected ways, occasionally tipping the balance toward the exact kind of self-targeting antibody production that defines drug-induced lupus. It's less the drug directly attacks you and more removing one piece from a complicated machine occasionally causes a different piece to start behaving strangely. And just like minocycline, this version breaks from the classic script. TNF inhibitor-induced lupus more frequently shows up with a different antibody signature than the traditional form, and less frequently triggers the textbook marker doctors expect. It's also worth noting that most cases of TNF inhibitor-induced lupus resolve after switching to a different medication class entirely, rather than necessarily stopping biologic treatment altogether, meaning patients generally don't have to choose between managing their original inflammatory condition and avoiding this specific side effect. They simply switch lanes to a different mechanism. Twice now, the newer drugs on this list have shown up wearing a slightly different disguise than the classic 1950s-era drugs that started this whole investigation, which is exactly the kind of detail that keeps this a genuinely active, evolving area of medicine rather than a solved case from decades ago. If discovering that even your rheumatoid arthritis medication could theoretically cause a different autoimmune problem made you do a double take, type ironic in the comments. Medicine has a sense of humor sometimes, and it is not always a kind one. Category 5, and this is the one most people watching this have currently sitting in their kitchen cabinet without a second thought: acid reflux medications. Specifically, proton pump inhibitors, the PPI family, with omeprazole as the most recognizable name. Regulatory drug labeling specifically flags omeprazole's association with drug-induced lupus, particularly a skin-focused version called subacute cutaneous lupus. And PPIs aren't traveling alone on this one. Calcium channel blockers, ACE inhibitors, and beta blockers, three of the most commonly prescribed blood pressure medication families on the planet, all carry documented associations with this same skin-focused subtype. Pause for a second and think about how many people are on at least one of the drugs in this specific category. PPIs are among the most commonly used medications in the entire world, frequently taken for years for something as ordinary as chronic heartburn. Blood pressure medications from these specific families are prescribed to a significant chunk of adults over 50. This isn't a rare combination of niche medications, this is genuinely one of the more common medication categories on Earth, which is exactly why this particular subtype deserves more public awareness than it currently gets. Let's actually pause on that specific subtype for a second, because subacute cutaneous lupus sounds like a mouthful, but it's worth understanding on its own terms. Instead of the classic joint pain and fatigue picture, this version shows up primarily as a rash, often in sun-exposed areas, often ring-shaped or scaly, frequently made worse by sunlight in a way that can genuinely fool both patients and doctors into assuming it's a straightforward sun allergy or a stubborn case of eczema rather than an actual autoimmune reaction to a medication. Patients dealing with this version often spend months trying various eczema creams, sunscreens, and dermatological treatments that only partially help, simply because nobody's connected the rash back to the heartburn pill or blood pressure medication sitting quietly in their daily routine, doing its part completely unnoticed. There's actually a rarer third subtype worth naming briefly for completeness, even though it's considerably less common than the other two: chronic cutaneous lupus, most frequently linked to certain chemotherapy-related medications and, occasionally, to some of the same NSAIDs many people take casually for everyday aches and pains. It's rare enough that it doesn't deserve its own deep dive today, but it rounds out the full picture of just how many different medication categories intersect with this condition in one way or another. Now here's the part that turns this from interesting medical trivia into actually useful information you should hang on to. How do you actually know if this is happening to you, and what happens once you find out? The classic symptom picture looks a lot like regular lupus, minus most of the scarier stuff. Joint pain and swelling, muscle aches, unusual fatigue, sometimes a low-grade fever, sometimes chest discomfort that gets worse when you take a deep breath, sometimes a facial or body rash. The good news, and I mean genuinely good news here, drug-induced lupus tends to be a gentler cousin of the real thing. Severe complications like kidney or brain involvement are considerably rarer in the drug-induced version compared to the disease that develops on its own. I want to walk through the timeline a little more specifically, because that's often the single most useful clue in actually catching this. This isn't a same-week reaction. Symptoms of drug-induced lupus typically develop after months, and sometimes years, of continuous use of the culprit medication. The documented range stretches anywhere from about 1 month all the way out past 10 years of exposure in some recorded cases. That long, slow-building timeline is precisely why so many patients and doctors miss the connection entirely. If you started a new blood pressure medication 3 weeks ago and suddenly feel awful, drug-induced lupus is unlikely to be the culprit. That timeline is too short. But if you've quietly been on the same medication for 2, 5, 10 years, and new joint pain, fatigue, or a rash shows up seemingly out of nowhere, that long, uneventful history is exactly the setup this condition tends to hide inside. If you're currently mentally cross-referencing your own symptoms against a medication you're taking, type checking in the comments. That instinct is exactly the right one to have. Diagnosis leans heavily on one specific blood test, the antihistone antibody. In classic drug-induced lupus, think hydralazine, procainamide, quinidine. This antibody shows up positive in the overwhelming majority of cases, making it a genuinely reliable clue for your doctor to chase down, especially when paired with a positive general antinuclear antibody test and a timeline that lines up with starting one of these medications. A good workup typically also includes a broader antinuclear antibody panel to look at the overall staining pattern. Plus, depending on which drug is suspected, some of those secondary antibody markers we mentioned earlier for the trickier cases like minocycline or TNF inhibitor exposure. There's no single universally agreed upon diagnostic checklist for this condition the way there is for some other diseases. A lot of the diagnosis genuinely comes down to clinical detective work, matching the symptom picture, the antibody results, and critically, the medication timeline, and then confirming the theory by watching what happens once the suspected drug gets removed from the equation. And here's the actual plot resolution, the part that makes this entire condition so much less terrifying than regular lupus. Remove the offending drug, and in most cases, drug-induced lupus simply resolves. Not manages. Not controls. Resolves. Symptoms typically fade over weeks once the culprit medication is stopped. Some patients do end up with more persistent symptoms requiring short-term treatment, most commonly hydroxychloroquine, the same foundational medication used for regular lupus, but even then, this is generally a temporary bridge rather than a lifelong sentence. Worth being specific about that timeline too, since it goes away can sound vague without a real number attached. Most documented cases show meaningful symptom improvement within 4 to 6 weeks of stopping the responsible medication, with the underlying antibody levels sometimes taking a bit longer, occasionally several months, to fully normalize on follow-up blood work even after the symptoms themselves have resolved. That gap between feeling better and labs fully back to baseline is normal and expected, not a sign that something's still wrong. The antibody clearance genuinely just lags a little behind the clinical recovery. If knowing this is actually reversible in most cases just took some weight off your shoulders, type relieved in the comments. This isn't the "you have lupus forever now" story most people assume it is. Let's clear up a few myths before we wrap this up, because a topic like this attracts some understandable but incorrect assumptions. Myth: if a drug can cause lupus, I should just stop taking it immediately to be safe. Reality: please don't do that without talking to your doctor first. These medications are prescribed for genuinely serious conditions: uncontrolled blood pressure, dangerous heart rhythms, active infections, inflammatory arthritis, and abruptly stopping some of them, especially blood pressure and heart rhythm medications, carries its own real risks. The actual right move is being aware of the symptoms and bringing them up with your prescribing doctor, not self-managing a medication switch. Myth: drug-induced lupus is basically the same disease as regular lupus, just with a known cause. Reality: as we just covered, it tends to be considerably milder, rarely affects major organs the way spontaneous lupus can, and, critically, usually resolves once the drug is stopped, rather than becoming a lifelong condition to manage. Myth: since these are common medications, drug-induced lupus must be common too. Reality: for most drugs on this list, outside of hydralazine and procainamide specifically, the actual incidence is under 1%. This is a real, documented phenomenon worth knowing about, not a reason to view your entire medicine cabinet with suspicion. Myth: if my doctor never mentioned this side effect when prescribing the medication, they must not know about it or must not be taking my safety seriously. Reality: for lower-risk drugs on this list, with incidence rates well under 1%, most prescribing guidelines don't require this specific side effect to be discussed at every single prescription. the same way doctors don't walk through every possible rare side effect for every medication they prescribe. It's simply not practical to cover every documented rare reaction verbally at each visit, which is exactly why general awareness videos like this one, and reading the actual medication information sheet, still matter. Let's do a quick rapid-fire round before we close this out. I'm on one of these medications and feeling totally fine. Should I ask for the antibody test just in case? Not necessarily as a routine screening if you have no symptoms at all. This isn't typically recommended as blanket preventive testing, partly because a positive antibody result without any actual symptoms doesn't reliably predict who will go on to develop clinical drug-induced lupus versus who will simply carry a positive lab value indefinitely without ever feeling unwell. But it's absolutely worth knowing the symptom list we covered, so if joint pain, unusual fatigue, or an unexplained rash ever shows up, you can connect the dots quickly instead of chasing the wrong diagnosis for months. How long does someone usually need to be on these drugs before this can happen? It varies enormously by medication, but months to years of continuous use is the general pattern rather than something that shows up in the first few doses, which is exactly why it's so easy to miss. Nobody's expecting a side effect from a medication they've already been safely taking for a long stretch of time. That long, quiet gap between started the medication and symptoms finally appear is genuinely the single hardest part of catching this condition early, and it's exactly why simply knowing the pattern exists, the way you do now, matters more than any specific test. Does this mean I'm now more likely to get regular lupus down the road? Generally no. Drug-induced lupus and spontaneous lupus are considered distinct phenomena, and having the drug-induced version doesn't typically predict developing the idiopathic form later, though anyone with ongoing symptoms after stopping the medication should stay under a rheumatologist's care just to be thorough. If I switch to a different medication in the same class, will the same thing happen again? Not necessarily, and this is actually one of the more encouraging details in the research. Because different drugs, even within the same broad category, can have quite different chemical structures and different metabolic pathways, switching, say, from one blood pressure medication to a different type entirely, frequently resolves the issue without triggering a repeat episode. That said, deliberately rechallenging with the exact same drug that caused the reaction is generally avoided, since symptoms have been shown to recur reliably when that specific pattern is tested. Here's what I want you walking away with. This isn't a video meant to make you suspicious of your prescriptions or your doctor. It's meant to hand you one specific, useful piece of pattern recognition. If you're on any of the medications we just covered and you develop joint pain, unusual fatigue, or an unexplained rash that doesn't match why you started that medication in the first place, that combination is worth a direct conversation with your doctor, specifically mentioning drug-induced lupus by name, rather than assuming it's unrelated. I also want to leave you with a slightly bigger picture thought, because I think it's genuinely the most useful mental model to carry out of this entire video. Your body is not a fixed, static thing that either has a disease or doesn't. It's constantly responding to everything you put into it, including medications that are, on the whole, helping you far more than they are hurting you. Drug-induced lupus isn't proof that medicine is dangerous or untrustworthy. If anything, it's proof of how closely modern medicine has studied even its rarest side effects, closely enough to name them, characterize them, and, in the vast majority of cases, reverse them completely once identified. That's not a scary story. That's actually a pretty reassuring one, once you see the whole picture instead of just the scary headline version. If this connected some dots for you, or for someone you know managing blood pressure, heart rhythm, or inflammatory conditions with long-term medication, send it their way. And if you want to go deeper on the autoimmune side of things generally, go check out our breakdown on the 20 body parts autoimmune disease can quietly affect. A lot of what we covered today about hidden, easy-to-miss symptoms applies just as much there. Type next in the comments and tell me which medication category you want a deeper dive on. Know your medications. Know the symptoms. And never be afraid to ask your doctor, could this be the drug talking? I'll see you in the next one.